Hello, everybody. We will go ahead and get started. On behalf of Seattle Children's Physician Relations Team, I would like to welcome everyone to our virtual CME Evaluation and Management of Functional Constipation. And that will be followed by a segment featuring Dr. Ruth McDonald, who is our VP and interim CMO at Seattle Children's, and she'll do an overview of our response to COVID-19 and our emerging telehealth platform. Just wanted to say before we begin, everybody is on mute and we will do our best to try to get questions answered. Dr. Amber Simeon has said she'll stop periodically throughout her presentation, and then she will be available for 10 to 15 minutes at the end of the presentation to answer questions that you have. So on that note, I would just like to introduce Dr. Amber Simeon. She has been at Seattle Children's in our GI department since 2013, and she is also medical director of our motility program at Seattle Children's. So Dr. Amber Simeon, if you would like to begin, that'd be great.
Thank you so much, Patricia. Thank you, everybody, for having me, and good evening. I'm very honored to be here, and thank you for the organizing body for arranging this. Today, we'll talk about the evaluation and management of functional constipation. Unfortunately, I have no disclosures, and the objectives of today's talk are to describe the evaluation of childhood functional constipation, to differentiate between organic and functional constipation, review the treatment, and become familiar with the national guidelines and the partner care model for management of patients with functional constipation. Functional constipation and defecation disorders in children come in a wide spectrum of diseases. They range anything from functional constipation and incontinence on your left-hand side to true disorders of motility, such as pseudo-obstruction, Hirschsprung's disease, and anorectal malformations, all of these presenting as defecation disorders. Contrary to popular opinion, defecation is actually quite a complex process. It is the intricate interaction between the extrinsic and the intrinsic innervation, the anatomical factors such as the colon and the sigmoid, sphincter function, colonic transit, the way our rectosigmoid functions and empties, the consistency of the stool, and the sensation. So essentially, all of these processes have to be in unison and work absolutely perfectly for stooling to take place effortlessly. And any deviation from the normal can result in a defecation disorder. Let's talk first about a little bit about epidemiology of constipation and incontinence. The worldwide prevalence of constipation can range anywhere between 0.7 to almost 30% in some developing countries. It presents in the first year of life in 17 to 40%, and it accounts for actually 3% of all visits to the general pediatric clinics. Though I do disagree with this, I do think it's a much higher number. And it definitely counts approximately a quarter of the referrals to pediatric gastroenterologists. It's a significant utilization of our healthcare services, 3.9 billion per year, and it has a significant negative impact on physical and psychological well-being of our patients, and the parents actually report to have a worse perception of their child's quality of life than the child himself or herself. Fecal incontinence accounts for up to 7.8% in terms of prevalence. And what's the most staggering and worrisome statistic about this is that 27% of those who are 11 to 12 years of age are the ones who seek medical care. And 38% of 5 to 6-year-olds seek medical care. So this leaves a significant proportion of our patients who, due to shame or worry, do not really present to us for treatment. It accounts for 3% of our referrals to teaching hospitals, and there's a significant male to female ratio of 3 to 1 to 6 to 1. What's very important about this statistic is that it has a significant impact on quality of life. There's significant behavioral and emotional disturbances associated with fecal incontinence, with self-esteem, social functioning, and learning disabilities. And what's important is that 30 to 50% of these patients actually meet DSM-4 criteria for mental illness. And most people seem to think that actually you have a mental illness and that's why you have incontinence. But in reality of it, it's the other way around. A significant portion of these patients struggle and suffer through all of this. The public health impact of childhood constipation is, as evidence has been very important for us to recognize. Due to its high prevalence, the healthcare burden, the complications, the psychological comorbidities, and it has a significant impact on family, social, and psychological life. So therefore, the impact of childhood constipation does affect all queries of our lives. The way we diagnose constipation is actually through what we call the Rome-4 diagnostic criteria, and that is an internationally derived consensus-based criteria to specifically diagnose functional gastrointestinal disorders. The following slide represents the criteria for functional constipation. The box on your left-hand side specifically refers to the criteria for infants up to 4 years of age. For the box on your right is for patients who are grade 4 years or greater, and then the box on the bottom, which was most recently added in the Rome-4 diagnostic criteria, is the one that pertains specifically to infants. The one important caveat made between the Rome-3 and the Rome-4 criteria was that it was very important to recognize constipation early in life and to initiate treatment early, as this has a significant impact on patients' function and morbidity. And therefore, the duration was changed from 2 months to 1 month. The evaluation and treatment of functional constipation is mainly based on the evidence-based recommendations by the European and the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. Here at Seattle Children's, the Seattle Children's Care Network has also come together to present a clinical protocol for functional constipation. And this is supposed to be a clinical protocol where we all unite with our primary care physicians in our communities to be able to provide more effective care to our patients with functional constipation. Here you can see is the SCC and functional constipation clinical protocol. I think the most important thing to take away from this slide, and we can make this available to you as well, is that this is truly a combined and effort between the gastroenterologist and the primary care provider, where through communication and collaboration, we make the best treatment options and the decisions for our patients. And we are and will be available to help you with all of the needs of your patients and your concerns as you manage them throughout their treatment course. The slide here highlights the essence of how we in gastroenterology, and specifically myself in motility, approach patients with constipation. Essentially, it's a comprehensive history with physical examination and Rome-4 symptom-based criteria. And with this, we essentially evaluate for constipation, but we also rule out disorders that mimic defecation abnormalities. And we also identify complications. It's really, really important for parents to perceive constipation as more of a chronic problem, meaning that it's asthma, similar to asthma, where you can have exacerbations, but you need a very stable management protocol. And therefore, we see them in clinic and we assess them. We initiate a treatment protocol, but we have to reassess them frequently to see if this treatment is truly effective or not. And if the treatment is not effective, then we have to reassess the situation and see if there's an underlying organic disease process that we could be missing. The following slide highlights the differential diagnosis of someone who may present with constipation. And actually, this slide truly scares me somewhat and has always scared me ever since I was a resident. Because here you can see you can have anything from botulism to Hirschsprung's disease to pseudoobstruction to multiple endocrine neoplasia type 2 present with constipation. The two important ones that I really want to point out are Hirschsprung's disease and spinal cord anomalies. Patients with Hirschsprung's disease present with onset of symptoms less than 1 month, usually. They do pass meconium greater than 48 hours. They can present with bloody diarrhea, bilious emesis, fail to thrive, and abdominal distension. And they can also have a tight, empty rectum that upon taking out of the finger, you can have an explosion of stool. Patients with spinal cord anomalies present weakness in the legs. They can have a dimple covered by tufts of hair on their back. They can have gluteal cleft deviation or absent anal and cremasteric reflexes, and decreased lower extremity tone and strength with abnormal reflexes of the lower extremities. So these two are the ones where I think having a neurological exam and a very careful history with careful follow-up, you would be able to quickly assess for. Some of the alarm signs and symptoms here to point out again is the passage of meconium greater than 48 hours. While up to 99% of neonates do pass meconium within 48 hours, the one thing we do have to keep in mind is that up to 50% of neonates who do have Hirschsprung's disease also pass meconium within 48 hours. And therefore, history of vomiting, abdominal distension, and also poor growth, especially in the first 6 to 1 year of age, are critical in terms of evaluating and having a high suspicion for Hirschsprung's disease. The common dogma used to be that Hirschsprung's disease was primarily diagnosed in the first month of life, but newer studies are also pointing out that actually 40% present in the first 6 months of life and 50% present in the first 1 year of life, with 93% presenting in the first 12 years of life. So technically, we can have even adolescents when they present with refractory constipation. Hirschsprung's disease is always in the back of our minds. Any patient who has a perianal fistula or abnormal position of the anus with abnormal rugae, we should have a suspicion for anorectal malformation. And of course, as I previously noted, any abnormalities, neurological abnormalities, should raise concern for spinal anomaly. And again, if you see anal scars or extreme fear during anal inspection, then sexual abuse is going to be high on the differential. Careful history and physical exam are the cornerstone in evaluating for these patients. The age of onset and the duration of symptoms should always be assessed in the context of developmental history and toilet training habits. For patients who are chronological age 8, but they have a development of a 2-year-old, then it's going to be very difficult for them to be completely potty trained as per parental expectations, specifically if their developmental age is so delayed. Some bowel habits are really critical to assess, such as the frequency, the consistency, if they have pain or bleeding with stooling, or any withholding behavior or extreme fear of the toilet. Also, the fecal incontinence, the consistency, the frequency, and the diurnal variation. Patients who mainly stool at night when they're sleeping are the ones who are classically thought of as the patients who withhold during the daytime. And also, some of the worrisome red flags that you may see include nausea and vomiting, decrease in appetite because of constipation from abdominal distension leading to weight loss, patients who have urinary symptoms such as urinary retention needing catheterizations, or others who have neurological symptoms as well. Patients classically say that the child has been walking on tippy toes. That could be a classic sign of tethered cord. With regards to the past medical and the surgical history, it's important to know if they have any congenital anomalies, such as patients with Mowat-Wilson disease and those with FOX2B deletions and others with trisomy 21. Those are at high risk of having Hirschsprung's disease, and therefore constipation in these populations, especially if it is not responsive to medical therapy, then Hirschsprung's disease is very high in our differential. Notable history that I always ask is how many inpatient clean that's have they had. And I always emphasize this to our residents. They're very much used to having patients come in for inpatient cleanouts, but that's not really normal for the general patient who had the 80 to 90% of patients who have constipation. Those who have recurrent abdominal distension and vomiting requiring hospitalizations, that's a problem. Patients who have fecal impactions that require disimpaction under anesthesia, or those with urinary retention requiring catheterizations, then those patients definitely get an MRI of the spine. Psychosocial history is also very important, especially if there's any history of physical abuse, sexual abuse, or emotional abuse. And also family history. Those with Hirschsprung's disease in the family then that raises my suspicion for Hirschsprung's disease or cystic fibrosis or celiac disease as well. And medications such as anticholinergics, which can increase your risk of constipation. A meticulous physical exam is very critical. I pay very special attention to the growth parameters, especially for the infants who present. I always monitor for abdominal distension, for vomiting, and growth. Patients with classic Hirschsprung's disease are the ones that are vomiting a lot and they don't gain significant weight and they're kind of bordering on failure to thrive and are the ones who constantly have significant abdominal distension. I do a very specific perianal examination and I'm very detailed about it, but it doesn't always have to be done at the first visit. You can just take parts of it. Look for the anal position. Patients report that they don't have any incontinence, but when you do the perianal exam, you can see feces, erythema or skin tags and fissures and hemorrhoids or extreme fear or scars. Also, I look for the rectal examination. I look at caliber. Does the patient have anal stenosis? I look for the radial corrugations. Are they symmetrical? Is there explosion of stool after I withdraw the finger, which would make me worried for Hirschsprung's? Or how's their rectal tone or caliber? I look at the spinal anomalies, looking for dimples, and of course, a complete neurological examination as possible. The following are just some examples of abnormalities. In figure A, you can see that there's a gluteal deviation by the line. And then the arrow is showing actually the anal opening. Here you can see that the anal opening is too close to the scrotum, but also you don't see the classic rugae of the mucosa near the anal canal. And what you're seeing is this punched out appearance. In B, you can see that there's a gluteal deviation here too. And in a patient who's refractory to treatment, then I worry about a spinal tethering or a lipoma. And again, in C, you can see the dimple, and it's actually not within the gluteal cleft, it's outside of the gluteal cleft. And again, that's worrisome for any spinal anomalies. This is an example of a patient with anorectal malformation. Again, you can see there's the anterior or lateral placement of the anus. You do not see any radial corrugations. If we did a rectal exam, it would actually feel very tight and the caliber and the tone would be off. You can see that you may not see an anal wink, or if you do see an anal wink, you will see it more posteriorly in this case. And you would look for any spinal dimples or tufts, and the patient may have abnormal genitourinary or neurological symptoms. Prior to moving to our next phase, I just wanted to see if anybody had any questions regarding what we have talked about so far.
And again, you can just type them in the little chat button that's at the bottom of your screen. It's like the little, it has a little like paragraph like icon.
And I
I
will
don't see anybody.
And please feel free to ask questions, and I will stop periodically as well. With regards to goals of treatment for constipation, the goals are to facilitate colonic emptying, to ensure fecal continence, especially for the patients who are incontinent, and most importantly, to preserve colonic neuromuscular integrity, and the overarching goal of improving quality of life. Now let's talk about the specific types of treatments. Now, what are some of the non-pharmacological treatments? Of course, dietary fiber. There's two kinds, soluble and insoluble. Soluble is actually a bulking agent. So when somebody's very constipated, you don't want to give them soluble fiber because it will just make the stool more bulky. You want to give them insoluble, which it doesn't get dissolved. It binds to bile acids and makes the stools loose. On the other hand, if you have a patient with primarily significant fecal incontinence, that's the patient where you do not want to give insoluble fiber because it will make the stools looser. Fluid intake is also very critical for patients to have adequate fluid intake and physical activity. Probiotics and prebiotics and behavioral therapy have not proven to have any significant role in treatment of constipation. I always tell patients that if there isn't, and physicians, if somebody has underlying behavioral struggles, especially with toilet sitting, toilet refusal, then of course behavioral therapy in that type of setting is absolutely appropriate. But regards to fiber, fluid intake, and probiotics and prebiotics being as the sole treatment in somebody who meets Room 4 criteria for constipation, that has not been supported by the evidence. There's conflicting thoughts about it. The question of biofeedback is also very interesting. Adults and in the field of urology, biofeedback has been extremely successful in helping patients with constipation. Unfortunately, in pediatric constipation, biofeedback has not proven to be of any benefit. However, emerging are the pelvic floor therapy or pelvic physiotherapy. These two studies, and there was a third one also on the way, is that have shown that there's actually some benefit to pelvic physiotherapy, and the studies are very promising. The study on the top, Benninga et al. From the Netherlands, did a randomized control study of pelvic physiotherapy compared with standard medical treatment. The standard medical treatment consisted of behavioral treatment, laxatives, dietary changes, and diaries, and plus or minus pelvic physiotherapy. The patients who had pelvic physiotherapy in combination with standard medical therapy actually did superior. It was 92% versus 68% in terms of effectiveness, which was really reassuring. A similar study was done in patients with fecal incontinence who have pelvic floor dyssynergia or pelvic floor dysfunction. And the study by Chumbitazi et al. From Texas Children's, they did a retrospective study evaluating the success of pelvic physiotherapy in this population. And they reported that actually their fecal incontinence episodes significantly decreased, and the patients needed less medication and had increased number of bowel movements throughout the week. So therefore, while pelvic floor therapy has been a new paradigm in management of constipation and fecal incontinence, we are very heavy proponents of it. But the one caveat is that not every pelvic floor therapist is trained in pediatrics because this is primarily an adult practice. So it's very important to work with the teams that you have to make sure that they are appropriately trained in pediatrics. We in GI and in urology have actually come together and formed a list of the trustee sites, and I'm more than happy to share that list with you as well. How about pharmacological treatment? There's multiple different options in terms of pharmacological treatment, and we will go through each one of these in more detail as the slides progress. We have the osmotic laxatives, which is your Miralax, polyethylene glycol. We have lactulose, and we also have milk of magnesium. Fecal softeners include mineral oil and docusate. The stimulant laxatives include senna and bisacodyl, and then the enemas and the suppositories. Just to keep in mind that there are no randomized controls trials for optimal dosing for these. The following table is only for reference in terms of the dosages that were done by our ESPGHAN and NASPGHAN guidelines, but throughout my slides, I will also give you the dosages as recommended by Seattle Children's Formulary. When we start about a pharmacological treatment, before we start the maintenance, we always want to assess if the patient has an impaction. Because, and the way I usually describe to the parents is that if the bottom of the pipe is plugged, it doesn't matter how much you put from the top, it's just not going to get us to where we need. And therefore, we recommend a fecal disimpaction. The guidelines recommend anywhere between 3 to 6 days of either PEG or rectal enemas, but honestly, 6 days of rectal enemas or PEG is quite a torture for the family and for the patient. So we usually do a 3-day clean out, and we have tables that include PEG dosing and stimulants that are available on our website as well, and I'm more than happy to supply them. In general, when somebody is on your rectal exam has significant stool in the rectal vault, those are the patients where I think they would benefit from rectal enemas, 1 enema per day for 3 days. The one thing to keep in mind is that there are multiple different types of rectal enemas. And when we say normal saline, that usually refers to sodium phosphate. And we have to be careful about how we use sodium phosphate products, especially patients with renal insufficiency and cardiac dysfunction, because patients who are specifically the ones who are withholders and they retain the enema, we do not want to be giving these patients enemas day after day because the retaining of the enema can cause hyperphosphatemia, hypocalcemia, and hypokalemia. So the patients who are significant withholders, I actually do not use the sodium phosphate enemas. How about the maintenance treatment? The first line treatment is polyethylene glycol with electrolytes. It has been shown to be more effective than placebo, lactulose, and milk of magnesia, and mineral oil. I like to give Miralax mainly to patients greater than 12 months of age. Sometimes I'll give it to 9 to 12 months, but primarily over the 12 months of age. Lactulose, on the other hand, while it can cause some discomfort and gassiness, I do prefer this for some of the younger patients, especially those between 6 to 12 months of age, and also between 4 to 6 months of age as well. Some of the additional second line treatments include milk of magnesia, mineral oil, and stimulant laxatives. Honestly, mineral oil can be very messy, and especially if somebody has fecal incontinence, I'd stay away from mineral oil because it can just make things so much worse. For those patients, I prefer milk of magnesia over Miralax because milk of magnesia has a stimulant effect as well as a laxative effect as well. So therefore, that's my kind of first line for those types of patients. For milk of magnesia, there's different types of magnesium products, and the one thing to keep in mind that magnesium products are overall poorly absorbed in the intestine, and they create a hyperosmolar intraluminal environment. So we have to be careful for those who have cardiac and renal disease, and here are the doses I've listed for you here from our formulary. One thing milk of magnesia is not very tasty, so a lot of times patients would tell me, well, it doesn't taste very well, and I don't know if my child can take it. For those, I recommend the Pediallax Chews. The brand is Pediallax, and there's the little tiny watermelon flavored chews, and the dosages here are based on the boxes, on what's recommended on the box. Again, phosphate and magnesium products, just be careful in terms of using it. My usual go-to, if a patient tells me my child will only have a bowel movement twice or once a week, I try to stay away from magnesium products because of risk of hypermagnesemia. Well, how about the stimulant laxatives, senosides and bisacodyl? There's a lot of talk about the senosides and bisacodyl, but causing what we call colonic inertia, or it makes the patient become dependent. Unfortunately, a lot of these studies were done in the 1960s and on very high dosages of senna product on mice and rats. So it's very difficult to interpret these studies based on current criteria. And some believe even the senna product that was used in the 1960s and 70s is different than now. Patients are constantly worried that my child will become dependent. I say it in terms of that, if you were on hypertension medications or cholesterol medications, yes, you are dependent on them because you need them. So in this case, we evaluate the risk-benefit ratio of Senna and bisoprolol and then have them use it as a maintenance medication. Senicides are anthraquinone laxatives. They're actually activated by colonic bacteria. It increases fluid secretion and alters colonic motility and transit. There's two studies specifically looking at senicides. First one by Santos Jasso et al. Is a randomized controlled trial, which was done in patients with anorectal malformations, comparing Senna to Miralax. And the study was actually terminated early due to the interim analysis showing clear benefit of Senna over PEG. The second one, which was done by the same group, actually is an analysis of all of the is a systematic review of Senna and its safety profile, and they found it to be that it's safe for long-term use. The only negative side effect for Senna is that it can cause a perianal and blistering rash with high doses, and this is dose dependent, and some believe it's because of the increased skin to stool contact. So if a patient develops this, I just decrease the dose or I stop it and then retry it. It just depends how bad the rash is. And then the second problem is that it can discolor the colon. And at this time, we do not have any evidence that discoloration of the colon can have any negative impact later in the future in terms of cancer. Here are some of the medication, the Senna products in terms of the syrup, the tablets, and the X-Lax chocolate squares and the dosages. The one thing I think I want to mention here is that the chocolate squares, even though the dosage is 15 milligrams per square, they're actually weaker than the syrup. And the syrup is actually weaker than the tablet. So I myself don't do a one-to-one conversion. I equate one chocolate X-Lax square, which is 15 milligrams, to one Senna tablet, which is 8.6 milligrams. And it's really important to ask the patients where they actually get the Senna tablet from and what does it look like, because there's 8.6, 15, and 25 milligram tablets, so that can be very confusing. For them and for us as well. To be honest, I go once a month and stand in Walgreens or CVS, and I just look at all of the different aisles because at times the companies come up with new tablets and formulations that surprise me. And therefore, it's really important to be able to clarify exactly the type of Senna product. The other thing to keep in mind is that when a patient is stable on a specific type of medical product, it's really important for them to always stick to that specific brand from that specific store, because we know there's a 15% bioavailability difference between all the different products. How about bisoprolol? Bisoprolol is a diphenylmethane laxative with primary colonic site of action. It increases fluid secretion, decreases colonic transit, and directly stimulates colonic motor activity. And it has been shown to be effective in both acute and chronic constipation and safe. And therefore, again, we do use bisoprolol for some of our patients as well. And here are the dosing listed here as well. Just something to remember, that the problem with bisoprolol is that we can't actually crush it. If you crush it, it takes the protecting coating away, and the acid in the stomach will deactivate the medication. So therefore, we're limited to only the patients who can swallow pills. How about some of the enemas? There's many different types of enemas, and the problem is that they all have under the same or few different brand names. So the brand name Fleet and the brand name Pedilax have multiple different formulations of sodium phosphate, sodium docusate, mineral oil, bisoprolol, and glycerin enemas. Usually for the little patients less than 1 year old, I like to use the Pedilax glycerin suppositories, even though they're liquid. It says liquid glycerin suppositories on the bottom of your slide. Those are usually my go-to, and they're very effective, and it's a very small volume. With regards to the suppositories, again, pediatric and glycerin suppositories, and also bisoprolol suppositories as well. Less than 5 years of age, I do half a bisoprolol suppository. Greater than 5 years of age, you can do a full suppository. Any questions about the about the treatment specifically, about the drugs before I move on? Okay, I will move on to the next part, which is the treatment. There's usually the treatment of constipation can be quite confusing, to be honest. The guidelines recommend that patients should be continued for at least 1 to 2 months and then should be taken off the medications. But that's very difficult to assess because it does take them 1 to 2 months to actually become continent or become constant with the medications. And then when we take them off of the medications, many of them do rebound. So therefore, for us in motility and in our GI, we do keep them on for 3 to 6 months at least. And then we do take about 6 to 12 months to discontinue the medications. And the one recommendation I have is if they're on medications and then they start potty training, I would keep them on the medications through potty training and then a year after trying to slowly wean them off of it because they do need that stability. With regards to prognosis, and the reason why I'm speaking so much about the duration of treatment is because 50 to 60% only recover in a year, and another 50% in 5 years, and 80% in 10 years, which means that actually 50% of them fail and relapse in a year, and another 50% in 5 years. So these patients actually need very close follow-up, and reinitiation of medication is very critical to get them stable. It's important to also mention to the parents that the medications that the laxatives that the patients are on, 25 to 30% of them are going to be may be dependent on some of these into their adulthood, and they may need laxatives for greater than 10 years. Therefore, early and adequate treatment contributes to successful outcome.
Dr. Amber, Simeon?
Yes.
I'm sorry. I have two questions that came up down in the question and answer section. So one of them is, it's from Nancy Baxter. How old a patient is pelvic PT effective?
That is actually a really great question. Our colleagues here, when we speak to them, it's mainly, to be honest, it's either anywhere between 6 to 8 years of age and older. I mean, if you have a very savvy 6-year-old, then that would be fine. But usually it's like 7 and 8 and above. And even for me to be able to do specific testing, to be able to gauge their sensation and how they squeeze and push, I require for them to be at least 8 years of age. So I'd say if they're a very savvy 6 to 8-year-old, you can refer them. But in general, over the age of 8 is going to be helpful.
Okay, and then the other question from Nancy Baxter as well is, how do you best determine the degree of impaction?
Oh, for fecal impaction, yes, the degree of impaction. So
Yeah,
that's also a very good question. And that can be also tricky depending on the patient's body habitus and how easy or difficult your physical exam could be. I always try to see if I can feel the impaction on my abdominal exam. If I can feel the impaction on my abdominal exam in the suprapubic area, then that's, I would consider to be a significant impaction. But if I can't feel it, but I do a rectal and it's a hard stool in the rectal vault, that I would consider kind of mild to moderate as well. If you can't get a physical exam at all and you cannot do a rectal exam, then the only other option will be to do an abdominal x-ray. But that's if you cannot gauge the other two. And then depending on the presence of stool and what it looks like on the abdominal x-ray, you can gauge how severe it is. But that's a great question. Any other questions?
Okay, thank you. No more questions at this time.
Thank you. So what happens actually when a patient you have has alarm signs and symptoms or relapses after you take them off the medications, or they actually don't even respond to laxatives? If they have no significant history and have an otherwise reassuring physical exam, then you can refer them to us in GI, and we'll be more than happy to see them in clinic. If they have complex history, such as seizures, hypotonia, cystic fibrosis, then we ensure that a GI MD will see them. And then for patients who are referred specifically to our motility program, such as patients with Hirschsprung's disease, anorectal malformations, spina bifida, tether cord, or if they have concern for colonic motility, then those are the patients that will come to our motility clinic, and then we work with our surgical colleagues to initiate a bowel management program for these patients. And so how do one of the important questions that always comes up to us with regards to referral is to get labs or not to get labs. Routinely, the recommendation is that we do not get labs for routine functional constipation. But we do recommend them if a patient has alarm signs and symptoms, or if they are not responsive to medical treatment. Usually, though, I get thyroid labs, celiac, lead, calcium. I like to get a BUN and creatinine to assess their kidney function, especially if I know I'm going to put them on enemas, and potassium. For the cow milk protein allergy, we do not recommend any allergy testing. If you want, the recommendation is to trial 2 to 4 weeks off of cow milk protein and then to see if it has a significant impact. But I personally do not eliminate cow milk protein as a trial if they don't have any other symptoms. So if the labs are normal and you initiate a medical therapy and they're stimulant and laxative based and they fail, meaning that they're laxative dependent or are not responsive and they have intractable constipation, then you want to refer them for further testing, either to motility clinic or GI, and we will triage them appropriately. When we think of patients with constipation and fecal incontinence, we think of that 90 to 95% of them actually fall within the functional category and 5 to 10% within the organic. If they are laxative dependent and not responsive, if they have alarm signs and symptoms, or they're refractory to conventional treatment, then we start thinking about some of the organic causes, such as anatomic. That's where you have anorectal malformations, such as stenosis or stricture, neurologic, such as a tethered cord, metabolic, those patients with hypercalcemia, MEN2B, CF, other systemic diseases, drugs and toxins. And then lastly, once all of this has been ruled out by our gastroenterologist, then they are referred for neuroenteric testing. What I want to do next is to just talk about some of the different ways here in GI and also in GI motility we may test for your patients and some of the treatment options we may offer. So then when we do have a partner care model and we are sharing the patients with you, you as well know and are familiar with some of the different testings and the availability that we have to offer. With regards to the evaluation, we have multiple tools at hand. We have abdominal x-rays, contrast enemas, MRI of the spine, SITS markers, and motility testing of the anorectum and the colonic motility. With regards to the abdominal radiographs, the recommendations are we do not recommend the use of abdominal x-rays for diagnosing a functional constipation. The only time that I resort to an abdominal x-ray is in very special circumstances, when I have an unreliable medical history, unreliable physical examination, and then I'm unable to do a rectal examination. Another time for me to also do an abdominal x-ray would be if they have colonic dilation or to look for their sacrum. The following is an x-ray of a patient who was seen by one of our fellows for constipation and had had multiple abdominal x-rays and are in the emergency room. But what I think people failed to see was that the patient was actually missing a sacrum and hence doesn't just have fecal incontinence, but actually likely has neurogenic bowel because of the missing sacrum. The other thing that I like to use abdominal x-rays for is that if I put somebody on enemas or I did an aggressive clean out and they're still not responsive or I'm having difficulty assessing the situation, then I get the abdominal x-ray to assess specifically response to the specific treatment. But it's important to notice that the sensitivity, the specificity is very low in abdominal x-rays and how they are read. And also there's significant inter and intra-observer differences between all the radiologists. So I myself read all of my abdominal x-rays and do not rely on radiology. Well, how about the contrast enema? Well, in the past, the contrast enema, and presently also, it's recommended if you're looking for any type of anatomical abnormality, stricture, stenosis. Sometimes surgeons get it to look for the dilated redundant colon, for the caliber of the colon. But classically, contrast enema used to be recommended to screen for Hirschsprung's disease. In an institution, if you can offer a patient anorectal manometry, which we will discuss soon, instead of a contrast enema, then the recommendation is to move forward with an anorectal manometry to screen for Hirschsprung's disease, because contrast enema can miss 15 to 20%. And definitely, we do not recommend a contrast enema to screen for any neonate, anybody under the age of less than 1 month for Hirschsprung's disease with a contrast enema. So in the well baby nursery, if their patient has had greater than 48 hours or concern for Hirschsprung's disease for any reason, then the recommendation to move straight to rectal suction biopsy and to not get a contrast enema. And even if the contrast enema is normal, we should not be reassured by that. So what is anorectal manometry? It's another way for us to be able to assess and screen for Hirschsprung's disease, but it also gives me ideas about the neuromuscular properties of the anorectum. The patient is awake doing this, so there's no radiation and there's no anesthesia. Sometimes I may give them first aid to be able to have them be more calm. But a flexible balloon is introduced into the rectum and serial balloon inflations are performed to distend the rectum. I test for involuntary properties of the anorectum. I'm looking for the relaxation of the sphincters, and it can also test for sensation, squeeze, and bear down. to be able to assess for the sensation, squeeze, and bear down and see if they have pelvic floor dysfunction, I do not recommend giving Versed. So therefore, this is the first method we do. And we also do anorectal manometries from ages 3 months and above. So if a patient is sent for Hirschsprung's disease, we do anorectal manometry if they're greater than 3 months of age and rectal suction biopsy if they're less than 3 months of age. Well, how about if your physical exam or your history is consistent with a neuropathy, or if your anorectal manometry is worrisome and consistent with a neuropathy? Then we move forward with an MRI of the lumbosacral spine. Studies showed that spinal cord anomalies are present in 3 to 9% of patients who present with refractory constipation, who may or may not have neurological abnormalities as well. But routinely, we do not use an MRI of the spine, only in cases where we suspect an abnormality. Here in the right-hand side, you can see the filar lipoma. And if you do have a cord tethering from the filar lipoma, this can lead to progressive neurological damage to the bladder and to the rectum, and the patients will present with secondary fecal and urinary incontinence. The evaluation of transit we can do with radio opaque marker study. This is actually a very nifty way for us to be able to do it. And the most important thing here to gauge is that we give these little tiny markers and the patient swallows it and it travels through the intestine. And if it's all accumulated in the bottom in the rectum, then we know that the patient is withholding. But if it's evenly distributed, then the patient has slow transit constipation, may or may not have colonic dysmotility. And if it passes normally, then you know that the patient has normal colonic transit. What's important to note that you can have normal colonic transit and still have constipation. That's approximately 30% of the patients. And if you have abnormal colonic motility, you may or may not have an abnormal SITS marker study. An important thing about this SITS marker study is that you can also test patients when they're on medication. So if a family says, well, I'm taking the medications, but the medication is not helping, my child is not stooling, sometimes I actually give the SITS marker study on medications to see if the markers are passed. And if the markers are passed, then the child is stooling, and likely the incontinence could be made better with some behavioral modification. So what happens if the anal rectal manometry is normal? And then we evaluate the transit. And if the transit is abnormal, then we move forward with colonic motility study. The picture on your right, you can see the colonic motility catheter in a patient placed from the cecum all the way down to the rectum. And you can see this patient has very dilated colon, and you can see how dilated their sigmoid is here. The colonic motility study helps me evaluate it helps me measure the colonic intraluminal pressures and also to evaluate the neuromuscular integrity of the colon. I can see if somebody has a neuropathy or a myopathy. Here you can see a pressure topography of a colonic motility study. The higher the pressures, the warmer the color, the lower the pressures, the cooler the color. And here you can see these high amplitude contractions, which actually dictate how you have stooling, travel from the cecum all the way to the anal canal. And here we can see if the patient is withholding, if they have a total colonic dysmotility, or if they have segmental abnormalities. When we treat these patients, does anybody have any questions? I would like to stop about some of the things before I move on to some of the advanced treatment options that we offer. No? Okay. With regards to some of the treatment options, of course, when patients come to our clinic, we initiate the following pyramid, and this goes from the bottom, which is least invasive, to the top, the most invasive. For 80 to 90%, if more, of our functional constipation patients, we initiate stool softeners and what we call squeezers, or the laxatives with senna and bisacodyl. Very minority of the patients do we move forward with suppositories and enema, and then still a much more minority of patients will move forward to enemas and even surgery. The one thing I want to emphasize is that in reality, we can make anybody continent with an enema. But the problem is that you may be missing a significant organic disease. So when a patient comes in and they are dependent on enemas, that's when they get essentially the $1 million workup. Because you can have Hirschsprung's disease, spinal cord anomaly, or you can have myelodysplasia, and also colonic dysmotility, or an anorectal malformation. And with high volume enemas, we can make all 4 of those scenarios continent. Some of the medications you may see patients that you share with us have are very high doses of bisacodyl and senna. And when I mean high, I mean 100 milligrams of senna, 15, 20 milligrams of bisacodyl. Some of the other medications you may see is lubiprostone, which is a selective chloride channel 2 activator, and also other selective guanyl cyclase 2C agonists and selective 5-HT4 receptor agonists. These are not FDA approved. I always talk about the risks and benefits with the patients before I actually put them on these medications. For the patients who do not respond to these medications, then we move forward with suppositories, enemas, and high volume enemas. On the right-hand side, you can see that the different methods we use to be able to administer these enemas. And this allows them to be continent, to have predictable bowel movements, and then we move forward with treating them to be independent. Some patients are not able to administer the enemas by themselves, so therefore to ensure independence, we offer them antegrade continence enemas. This is a continent conduit from the skin to the cecum for self-administration of the enemas. The conduit can either be a cecostomy tube or it's a catheterizable channel through the appendix. But it's wonderful because it allows for complete emptying of the colon every day. It gives the patients predictable bowel movements, so they are socially continent, and most importantly, it gives them independence. In summary, functional constipation and fecal incontinence are common disorders of defecation in children that have a significant impact on quality of life. The evaluation of children with functional constipation is based on history and physical examination with limited role for laboratory and diagnostic testing. And the evaluation and treatment of functional constipation in infants and children is based on evidence-based guidelines from ESPGHAN and NASPGHAN. The Seattle Children's Care Network partners with primary care providers in the care of children with functional constipation. And I'm open to questions if anybody has any questions.
So again, if you want to chat, type in a question for Dr. Ambert-Simeon or send in the Q&A. I'm looking at those right now, and we'll give it a minute or two to see if people have questions. And hopefully you do, but if not, then we can, we'll move on. So.
And also, one other thing I would like to say is that if you have patients who have organic diseases such as Hirschsprung's disease, they have colostomy, cecostomy tubes, anorectal malformations, and they have incontinence, please feel free, to let me know. If you do refer those patients and for some one reason or another the referral is denied, please do not hesitate to email me because then I can arrange for these patients to be seen. I do see them specifically myself in coordination with our surgeons in our motility and surgical clinics.
Okay, so Dr. Ambert-Simeon, one of the questions that we got was, how long do you feel comfortable using Senna as part of the daily maintenance therapy?
That is an excellent question. I personally have patients on Senna for many, many, many years. One of the important things to remember that is if somebody is on Senna before toilet training, it's really important to keep them on Senna during those years that they are learning how to toilet train, and also a year or two after that. So definitely, I have patients who are on Senna for 2, 3, even 4 years. I think a primary care perspective, if you have somebody who's dependent on stimulant medications and you cannot get them off of it after a year, it would be really good if these patients are referred to GI and you partner in the care. Because then we can assess the patient and we can say, you know what, the patient is dependent on stimulant medications. I don't see or worry about any type of another organic etiology at this time. Please continue using it. And then you can keep using it, knowing that 25 to 30% are dependent on them as adults. But I do think if somebody is on it for more than 1 to 3 years, then it would be good to have the partnership of a gastroenterologist with you.
Thank you. I was also just going to note, I think all the attendees received Dr. Ambert-Simeon's bio card. And so if you did want to email her, like she mentioned earlier, it would just be her first name dot her last name at seattlechildrens.org. And your emails, I'm sure, on the bio card as well, but just to point that out.
Yes, and if you have any other questions or things come up, feel free. I'm more than happy to answer them. I think we have another question.
I don't think we have another question. Oh, wait, we do. Hold on a second. I gotta switch over because I'm getting them in different places here. Okay.
Yes, I see.
When should I Okay, so Chris Sadler asked, when should we refer to GI to partner in care other than after 1 year of Senna?
Okay, that's an excellent question. The Seattle Children's, and Patty, please, Patricia, please remind me. Can we also send out to all the participants the Seattle Children's Care Network guidelines that I presented, and I can send that to you as well. So one of the guidelines says, so if you see any red flags, which we talked about, any neurological symptoms, if you notice any abdominal distension, vomiting, weight loss difficulties, recurrent admissions to the hospital, all of those things would be very important to refer. So let's say you also put them on Senna and they're not responding to the Senna and you're considering increasing the dose, you would want to refer. If you have them on Senna for a couple of years and you can't take them off, again, it's important to refer. Or let's say you've done a couple of clean outs and you've put them on maintenance medications with Miralax and they're still not getting better, but you yourself don't feel comfortable initiating Senna, that's absolutely okay too. Please refer and we can initiate the Senna, assess for any organic disease, and then we can partner in their care with you. Usually the rule of twos is great. If they do not respond to 2 cleanouts or they do not respond to 2 changes of medications, please feel free to send them to us. We're more than happy to evaluate.
Okay, thank you. There are actually a couple of questions that popped up. Oh, go ahead.
Yes, no, please.
Okay. What percentage of kids with chronic abdominal pain have constipation as a primary cause?
So that's actually a very excellent question. And we ourselves in GI here constantly argue about this fact. So a significant portion, it's hard for me to tell you exactly the percentage of patients with abdominal pain where the constipation is a cause. I think it's mainly 20 to 25%. But I can tell you that when somebody does have abdominal pain, I do not tell the patients that the constipation is the cause, especially when I'm evaluating the abdominal pain. What I do tell them is that we have pain and there could be multiple triggers to this pain. One of the triggers could be constipation. And this is very easy to address. So why don't we trial 1 to 2 months of Miralax and see if this helps us? This is really important because sometimes when we start these medications and blame constipation, and these kids end up being admitted multiple times and getting multiple clean outs, and it's very difficult to assess what an quote unquote empty colon looks like. So that's why I always say that it's a trigger and then give it a good 1 to 2 months of trial on medications before I blame it. But if you trial the medication and the patient gets better, then yes, you can say, well, we found the trigger and then we're going to now to chronically address the trigger. But again, patients with chronic abdominal pain can have multiple triggers throughout the years. And therefore addressing it as a trigger versus a cause is going to be really important, both for treatment purposes, also for making sure that you don't miss any other organic disease.
Okay, and here is the next question from Carol Clark. I worry about those infants who are constipated in the first month. Maybe mom stopped breastfeeding and is trying different formulas. Don't want to miss the Hirschsprungs.
Absolutely. And I think that's a significant worry for you and for us as well. It's always those less than 6-month-olds always make me extremely nervous. I think these are the patients where having close follow-up in clinic is going to be the key. I sometimes bring these patients, of course, I see them after the fact, but if I'm worried, I bring them every month or so. So I would say in these infants, making sure that they're growing. So the growth chart is like the first thing that I pop up and I look in for these patients. If they're not growing, they're having significant vomiting, they're having distension, then those are the patients which I think could use further evaluation. So it's not just the constipation, but it's mainly the distension, the vomiting, and the poor growth that also you could use as kind of your tools to be able to make the decision. But absolutely, yes, these are patients who constantly give us a lot of angst.
Okay, I think that we are done with the questions and answers. So thank you, Dr. Ambartsumian. I appreciate that. And to now, I will unmute Dr. McDonald and introduce her. So thank you.
Thank you so much. Have a good day.
Bye. All right. Okay. Dr. McDonald, you are now unmuted. Everyone, I would like to introduce Dr. Ruth McDonald. Again, she's our Vice President and Interim CMO at Seattle Children's Hospital. And you know, we thought it would be great to have Dr. McDonald get on the call and talk just about our response to COVID, you know, where we're at, what we're doing in our regional clinics and hospitals for safety reasons, and then also talk a little bit about how our telehealth program has evolved. And we would love, like, while she's talking, if you guys have some questions, advice, want to, just discuss further certain things, please feel free to, again, to add those into the chat box, and I will, when she's through, I will make sure I'll ask her those questions and get them answered for you. So with further ado, Dr. McDonald.
Hi, everyone. Thanks, Patty, for that introduction. And actually, I know many of you. I looked through the list and have a lot of friends there. Nancy Danoff and I were residents together, and we were out at Group Health. I remember that very well. And it was quite a long journey here at Seattle Children's. I really wanted to mostly answer your questions about COVID. We are in this for the long haul, and it has impacted all of us in very many ways. So I would really hope if people could just start asking questions. One thing I did want to talk about was testing for your patients and how you can get the results in a really timely manner. So what we've seen is that we are testing a lot of the community patients and really want to make sure we have resources to do that, especially at South Clinic. I have talked to Ben Danielson and Brian Johnston about where we really need to focus for our underserved communities. And we initially tried to set up testing at Odessa Brown, and it just logistically wasn't going to be a good fit for a variety of reasons. So we set it up at the urgent care at South, and really want to make sure that we serve that population really well. We currently always are struggling with supply of testing. We partner with UW, and so that's really fortunate because we can, once we hit our max of our daily capacity, we can send testing over to the UW. One of the issues that I've heard about, it's gotten escalated several times to me, is that, as you know, we're in the transition from going from Cerner to Epic, and how do we get results really fast? And so in some of our practices, we still have to do the autofax, and there are delays in not our autofaxing, but getting it into the medical record for you all to observe. And we're checking to make sure we have the right fax numbers. But always, if you can as soon as the results are available, they're in CIS, they're in the medical record. And the turnaround time at the longest is 12 hours. Usually we can, from collection of sample to getting it processed to getting it into the medical record is actually usually 6 hours, depending on when that sample hits the run. So our lab staff is fantastic, and currently we're really trying to troubleshoot any barriers. Many of the times these results are pretty time sensitive. So we have teenagers who are not symptomatic, but they can't go to college unless they have a negative test, otherwise they're quarantined. And so we do testing for that. We don't discriminate against whether it's symptomatic or asymptomatic. So we're available to do those tests for those sorts of reasons. So I just wanted to initially, start out with the testing, and just really want to hear what you guys want to ask me, and how we can help Seattle Children's to improve the experience for patients and families. I know one other concern is telehealth, and we are actively calling out to encourage families to schedule appointments when they haven't come into their, in-person appointment. There's certain times, as you all know, where you have to actually see the patient, examine the patient, and telehealth is not what is needed for that particular patient at that time. So we are sensitive to that. We have really encouraging one caretaker per patient because of the unbelievable challenge of social distancing, as I am sure you all are experiencing in your practices as well. So any feedback that that I can get from you to help with this situation and help getting your patients in, I'm really, we really want to hear it. So again, we're in it for the long haul, and what can we do to help?
Well, Dr. McDonald, one question I had from a provider was, when you do have those kids that need to be, say they're in quarantine, but, I don't know how we're out. So they need to be seen in person, but they're in a 14-day quarantine. They're not supposed to be getting out. So I was just curious if we'd had those conversations.
So if they need to be seen, they need to be seen. And so everyone is masking. And if someone reports that they have been exposed, our best practice is and are asymptomatic, we try to immediately get them or symptomatic, immediately get them into an exam room. So we don't want people, if they need to be seen, their patients, if they need to be seen, to quarantine for 14 days before they can come to Children's. We actually have adequate PPE at the moment. And so what we did right at the start, so I've been the incident commander for this for the entire time. And we, in January, really felt like, we were going to be in a world of hurt for N95s. And so we switched to cappers and put in a very large order. We have another order coming in. So our staff are protected from symptomatic patients. The asymptomatic patient, if they're masked and our staff have appropriate PPE, they should be, fine. The challenge is making sure that the patients and families wear masks. And as you can imagine, it's pretty challenging with the recommendation to have anybody 2 years and above to keep a mask on a 2-year-old is probably a challenge that we all didn't have to live with growing up, but now many of you with young children are experiencing it or having young children come into your practice.
And then another question that I have is, like special needs kids that are in their primary care doctors, and there's been some labs that aren't getting their results back very quickly, and they end up wanting to send that to us, but they don't, or they want that patient to get tested right away and get the result back right away. But because they're special needs, it's extremely difficult, right? Because of, they can't, it's hard for them to go to another clinic. So I was just wondering, or they were wondering, I should say, like, how are we're having that problem as well, right? So are we doing anything different with the special needs kids?
Sure. So one thing is that you can send the patients to Seattle Children's, the urgent cares get tested. You just put the order in and we will test them at urgent care, and our staff at the urgent cares are able to do the testing on the special needs children. So that's one thing. What was the rest of the question, Patty?
Oh, it's just one question. Like, I think part of the problem is that sometimes they'll be in there. Well, this is
specific questions actually
in there, and they want to get them tested, but nobody's testing quite as quick as we are. So they were wondering, like, if they could like test in their office and somehow courier it to us, right? That patient didn't have to then go from their office to an urgent.
That's a really good question. And so far we are not taking samples from the outside. And I will bring that back. We have a COVID advisory committee that meets twice a week. I'll bring that back to see, is there any way we could accept samples that were done outside? So we accept them from Odessa Brown, but that's Seattle Children's. And so far, I understand the challenge, and yes, we do have really good turnaround times, but I don't know. I don't think the UW accepts samples that were collected outside that are just sent to their lab, like a reference lab or like a Quest, those sorts of things. So it would be a institutional arrangement to be able to say UW or Seattle Children's is one of the labs that we just send samples to. So I'll look into it though. I'll check.
And I'm just, and then I guess I from people, so I'm just asking them on their behalf. But like with telemed, because we've heard that it's working great right now for COVID, but maybe in the long run, like reimbursement and things like that won't necessarily be the same. So I'm curious, like what kind of talks you're having with people to see how we can, use it going forward.
So Suzanne Peterson-Tannenberg is Seattle Children's vice president who represents government affairs, and we are lobbying heavily to make sure that these telemed visits continue to be reimbursed. I have to say that the feedback we've gotten from families has been outstanding, and they really, really like the telemed experience. The not having to drive through Seattle Children to traffic to Seattle Children's or one of the sites. Also the just convenience of not being, the whole travel, the waiting, the whole experience has been pretty positive. So we're getting great feedback.
Okay, then another question came in about will there possibly be testing available over in Eastern Washington, say Tri-Cities or Wenatchee?
Yes, we have not set up sites there to do testing. So I can check on that as well. That has to do more with state and public health. So it's really hard for us to set up separate testing sites throughout the whole state. Where we actually own the clinic, we could explore, so Tri-Cities, we could look at how can we have tests done, but then they have to get shipped to Seattle Children's and then run. And so I'm not sure the turnaround time would be quite as great, but it might be better than what you get with the commercial testing sites such as Quest or LabCorp.
Great. And then, like, how about our hospital? What's COVID look like in the hospital with patients? How are we doing?
Yeah, so that's a really good question. We are doing well. We have a few rooms in the ICU that we've dedicated for COVID patients, and then we have a ward in the main hospital for acute care COVID, and we have flexed up. We can flex up pretty high actually, but usually we're anywhere from 0 to 5 patients depending, and some are rule outs. So for example, if we're admitting a patient out of the emergency department and they have symptoms compatible with COVID, and let's say we do a rapid test and it's negative, and their symptoms appear that they could have COVID, we actually admit them to our special isolation unit. And that has happened more than once so this is one thing I want to tell everyone. If a patient has symptoms that are very much suspicious of COVID, one test doesn't rule out that patient doesn't have COVID. And so we admit those patients to our special isolation unit and treat them like they're COVID positive until we can really confirm what's going on.
How often do you do, like, you perform that one test negative? When would you perform the second test? Like another test, would you do it or not?
we would do it the next day. We've had one patient where we tested 4 times before they were COVID positive. And so this is a very interesting viral disease, but unfortunately, if you think a patient has COVID, you really need to be persistent on the testing. I see one question coming up about antibody testing for COVID. So, you know what, that's really interesting because to me, that's a research problem. We don't know how protective antibody to COVID is or what titer gives protection. So that's why we're not testing it on staff. We are waiting. Now, if someone, one of you all in the community wants to do antibody testing on your patients, you can do that without any restriction. But we, at Children's, the jury's still out whether it's protective. Our worry is that if you get the antibody testing and let's say we don't know what titer is protective, and then people get falsely assured that they're fine to go out in the community because they're going to be safe. And so we, for our staff, are not doing any antibody testing.
Okay, another question was how I'm not sure what this acronym is. MSIS-C patients have you treated so far at Seattle Children's?
You broke up a little bit there, Patty, so I didn't quite hear the question.
How many MSIS-C patients have you treated so far at Seattle?
I don't know what what's MIS dash?
MSIS, it's acronym.
I don't know that acronym. Sorry.
Okay, that's so. Dr. Danoff, if you want to send me another message, I will. If you want to be more clear, I'll.
Or you just unmute, Nancy. Can't you?
I can try. It's kind of a clunky screen. So but while I try to do that, here's another question. People are there. Any advice on how a PCP can counsel a family to go to the ER? It'd be safely.
Patty, I'm sorry, you're breaking up. I can't quite hear every word.
Oh, okay. People are delaying care. Any advice on how a PCP can counsel a family to go to the ER and be seen safely?
So they can be safely seen in the emergency department. We have valet with screeners out in the emergency department. If anybody has any symptoms that we have a symptomatic room and everyone's masked when they come in, but we have an area where if patients are suspicious or have a contact for COVID, we bring them immediately back into a room. Actually, just so you all know, our emergency room visits are way down. And we actually have seen more really sick DKA patients than we ever have because of people or families delaying coming into the hospital for care. So I just had a meeting last week with endocrinology about this. So just they really need to get care, and it is safe to get care. We have the appropriate PPE. We are doing all of the hygiene, wiping down of surfaces, making sure people are protected. And so it is really stressful. So I think Nancy's probably asking about those patients who, with COVID, who have that systemic infection or inflammatory disorder, correct? So we've actually seen quite a few. John McGuire is our spokesperson for this. He's been in the news talking about it. So fortunately, all of the children that we've seen have recovered, but we have seen quite a few where when we confirm antibody testing and then, so it's been really, really interesting, but fortunately all of our patients have recovered.
Okay. All right. I think gotta go check the queue. There's messages in different spots here, so it's
I'm so sorry that we can't unmute you all because I just kind of wondering how you guys are doing in your primary care practices. Like like what is it like for you? I get to talk to Melissa Welsh and about when they ran out of PPE and they used disposable rain gowns as or rain wear as ponchos as their gown. And so I'm just so wondering how it is for you all. And are your patients coming in for their primary care visits? I was on a WISHA call, press conference that went statewide, just saying, pleading, please make sure, especially for those children under 2 years of age, that they go for their well child checks so that they can get their immunizations, they can make sure they're doing their growth milestones, all those sorts of things. And I just was so wishing to get dialogue from all of you about how your life is under COVID.
I can certainly try to mute everybody, but then everybody who's not talking needs to mute themselves. Yeah, okay, that's okay. I'm going to try to unmute everybody just so you have the ability, but if you don't want to talk, press *6 or go mute yourself on the.
Great.
There we go. Let's see. Everybody should be unmuted now. So please feel free to ask a question. I think we might have just gotten it. Oh, what are the
patients? Yes. So it's been a variety. I would have to say more teenagers. Probably the majority have been teenagers. But it's covered in probably, I don't know, 5 to 10 days or so.
Ruth, is there going to be any long-term follow-up from Children's for the kids who've got the multi-system inflammatory syndrome associated with COVID?
Absolutely.
And through what, through infectious disease or through what clinic?
Through infectious disease. Working with Danielle to make sure that those children are there's no long-term sequelae. It's kind of similar to hemolytic uremic syndrome, right? Where some kids barely had it and we are following them long-term. See, I recognize your voice, Nancy.
It's been a long time.
Okay. Anybody else have any stories they want to share about how they're managing in their offices?
This is Ellen. I'm with the Everett Clinic, and Ellen Pasloff, and I just wanted to.
Voice too, Ellen.
What's that? Oh, you recognize my voice? Yeah. And I just wanted to let you know that we are bursting at the seams right now. We're getting all the kids in who needed to catch up on vaccines, and we've separated the fever and URI kids to our walk-in clinic, so that they don't actually come into our pod and contaminate the rooms. And we're in ongoing discussions right now about what we're going to do come fall, because that's not sustainable when there are going to be so many kids with fevers and colds. And we're probably going to have to start accommodating those kids as well as the well children. And we're working on that right now.
Fantastic. Hey, I just want to ask who's ever typing, they would mute. Someone's typing something serious on their computer. Man, they type way faster than I can. I think Laurel, is that you? No, it's not Laurel. It's not me.
Yeah, I'm not typing. Oh, wait.
All right, we'll just talk.
Sorry, hey, Patricia. Hey, it's Patrick Gately here at Visual.
Yeah.
Hey, you can usually tell who's speaking by like little speaker icons next to their names in WebEx. So if you see like little animated blue lines, that's easy to find who is making noise.
I don't see any, no, I don't, but
Yeah, it's kind of like a tricky game,
Yeah.
but I thought that.
okay. I think I see.
Dr. Corey, I think you're typing really loud. Can you mute yourself?
Is it Corey? Okay.
All right. So I think,
Son, probably Corey has a son or something.
it's almost time anyhow. I will just like open one last time if anyone would like to share any of their what's going on in their clinics. We'd love to hear or have any questions or ask of us. We would love to hear that.
So one thing we could do at another time is we could have everyone submit questions, and then Danielle, Zara, and I could do a talk for the group. And whether it's CME or not, it's just if the community would like to hear more and get direct answers, we could put together a panel for the community to
That's a
call
great
and then get their questions in advance, but then also have some as well that people like
That's great. That sounds great. We will definitely talk about doing that. So anyway, thank you everybody for taking the time out tonight, joining our CME and Dr. McDonald. And if when we sent the invite out, we did have a Google evaluation that we would love to get your feedback on the program and what you thought went well, any suggestions that you have. And yeah, so thank you very much.
Thank you.
All right. Bye.